Welcome everyone to the University of Toronto's Joint Centre for Bioethics seminar series. My name is Ruby Shankar and I will be moderating today's session. Our speakers today is Dr. Claudia Barned and Ms. Akosua Nwafor, and this seminar is entitled I Don't Want Any Black Nurses, Insights from the Academic Literature and Ontario's Regulatory Bodies on Navigating Discriminatory Requests or Refusals of Care Providers. Before I introduce today's speakers, I would like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar today is a presentation by our speakers and followed by a facilitated discussion period as much as is possible. I know we're going to have a lot of content to really have thought-provoking time for thought provocation, but maybe not having enough for discussion, but that's okay. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this is also the meeting land to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and study on this land. I also want to acknowledge those who came here involuntarily as a result of the transatlantic slave trade and slavery, particularly the ancestors of Black and racialized peoples who were forcibly brought to Canada to give their labor for free on this land. And now it is an absolute honor and my pleasure to introduce today's speakers. Dr. Claudia Barned is a bioethicist with the University Health Network, where she provides clinical and organizational ethics support to Toronto Western Hospital. She's also an assistant professor at the University of Toronto, where she recently designed and led a novel course on bioethics and racial justice through the Joint Centre for Bioethics. She's an education investigator with the Institute for Education Research, TIA, and an associate researcher with the Pragmatic Health Ethics Research Unit. With advanced training in social psychology and health ethics, Claudia's research has attended to issues at the intersection of both domains. Presently, her research focuses on racial justice in health and healthcare ethics more broadly. Akosua Nwafor is a bioethics researcher analyst at the University Health Network and a bioethicist at Ontario Shores Centre for the Mental Health Sciences. In her work at UHN, Akosua is involved in various quality improvement, research, and program development initiatives. She holds a Master of Health Science in Bioethics from the University of Toronto and an Honours Bachelor of Science from the University of Ottawa. Her previous work with the Centre for Ombuds, Resolution and Ethics at Health Canada combined organizational and workplace ethics initiatives through ethical risk assessments, revision of organizational codes of values and ethics education. Akosua is passionate about decision-making in clinical research, racial justice and equity, and access to care. Claudia and Akosua, on behalf of the JCB, welcome to today's seminar. I hand it over to you both now.
Thank you so much, Ruby, and hello, everyone. So Ruby, thank you again for the warm introduction, and thank you to the JCB for creating space for us to share this presentation today. So before we begin, I'd just like to acknowledge that the title of our presentation might be jarring for some, as it explicitly calls out the anti-Black racism very much present in our health system. The aim here is awareness and attention for our colleagues who are often on the receiving end of this very specific form of discrimination, and the importance of giving voice in hierarchies or clinical settings where this might not always be possible. So the aim of today's presentation is truly to highlight the distressing experiences that our colleagues go through and to collectively start thinking about how we can all make steps or take actions that support each other. So today's presentation is divided into 3 core sections, all of which aim to unpack the larger question of what exactly does the literature tell us about healthcare workers' experiences with discriminatory patients, and what professional or regulatory guidance is available for support. So to do this, we will start by contextualizing the problem and outlining the salient factors to be balanced. We will then situate the work within our local context and provide some background on the project from which this presentation stems. We will then present the preliminary findings from the scoping review conducted, which will be followed by Akosua's discussion on how and in what ways some of Ontario's regulatory bodies have attended to these issues. So the wider literature and social discourse on discrimination in healthcare is predominantly oriented around discrimination from healthcare workers to patients and the resulting inequities in the receipt of care and healthcare outcomes broadly. However, we would like to open up the conversation some more by recognizing that discrimination within healthcare occurs in multiple directions. So, typically from healthcare workers to patients, from healthcare workers to other healthcare workers, and the form that we're hoping to really unpack in detail today, discrimination from patients to healthcare workers. And so there has been a growing body of literature on this topic, including key articles by Paul Emile, Chandrasekhar, and Jane, and others exploring particularly racist requests for alternate care providers. And so what the literature reveals, as we tried to reference in our title, is that these requests are frequently wielded against Black nurses in unconscionable ways. And so the literature has detailed Black clinicians being called the N-word, being told that death is more favorable than being cared for or being touched by them. And in addition to, broader experiences of sexual harassment, physical violence, and just assault from patients and their families. And so these experiences are not exclusive to Black healthcare workers, of course, and so we'll unpack this later on. In dissecting this issue on a larger scale, we have to consider the psychosocial, the legal, the ethical aspects of this problem. And so from a legal standpoint, we can think about this in terms of rights. So healthcare workers have rights and certain protections that must be balanced with the patient's rights and requests. And so under the Ontario Human Rights Code, healthcare workers have a right to a workplace free from violence, from discrimination and harassment. And so under the Human Rights Code and also under OSHA, hospitals as employers also have certain duties and obligations as it relates to the safety and protection of their employees. So for example, healthcare workers must not be subjected to or made to endure continued exposure to violence, harassment, or discrimination, as any infringement of a protected ground would constitute a contravention of an employee's rights under the code. Furthermore, certain sections of the code invokes liability for organizations that fail to address underlying problems, such as systemic barriers, a poisoned work environment, or an environmental culture that condones discrimination. So what I'm trying to get at is that the code actually points to the fact that hospitals have an overarching duty to address this issue and may be liable where patterns are proven. So where organizations fall short on addressing these issues, they could be said to be violating the rights of their healthcare workers. So from an ethics lens, we think about balancing the tension among key ethical principles, most notably autonomy, beneficence, and the duty to care. Within healthcare, where we often think about this in terms of, ways to promote the patient's autonomy. However, in the context of bigoted requests, it necessitates conversations on the limits to autonomy and the limits to when and to what extent the patient's autonomy should prevail over the well-being and safety of the healthcare worker. And so in these instances, we may find ourselves at an ethical crossroads whereby a measured response is necessary. And so within the literature, we see the operationalization of these legal and ethical commitments reflected in zero tolerance policies. Now, there is some debate here regarding the efficacy of zero tolerance policies. So notably with respect to there being a disconnect between what they purport to stand for or what in theory they actually are grounded in and versus what they lead to or what they might amount to in practice. So, whether or not there are actual enforcement accountability measures that leaves healthcare workers feeling like they're actually supported. And so it's often the case that zero tolerance policies do not leave healthcare workers feeling like there are measures in place that provide the protection that they're asking for. And so although zero tolerance policies convey the message that organizations stand against violence, harassment, discrimination, and may contribute to a feeling of safety and support among staff, it's often the case that the boundaries of zero tolerance are vague and the limits of what it means are not clearly defined. And so where there is a lack of definition or a lack of clear delineation of terms, there, brings about this kind of vagueness and, leaves things in question. So we've been thinking about this broader issue in the context of clinical cases that arise in our local context at UHN. And so while UHN doesn't have a zero tolerance policy, we do have a guideline in place that we've recently went through the process of updating. And so what you're seeing on the screen is an image of UHN's caregiver preference guideline and algorithm, the 2007 version. That was a joint effort between bioethics and diversity and mediation at the time, now known as IDEA. So this guideline came about as a result of a need for an organizational response to this broader issue, as staff desperately needed support in navigating the various considerations that must be weighed. So, this was very much an issue in 2007, and it's still very much an issue today, in that we've seen significant increases in these incidents, which has led to the revisiting and revamping of the guideline. And so over the last year and a half, we've worked to update this guideline through a comprehensive multi-phase approach that includes a scoping review, assessment of the broader literature, including gray literature, stakeholder interviews with healthcare workers across UHN, and across policy analysis. And so today's presentation really dives into these two areas of the process, so the scoping review and an assessment of the gray literature. So this is where we noted input from the professional bodies. And so the aim of the scoping review was to understand the breadth and depth of what exactly healthcare workers experience as it relates to discrimination from patients. So to really also kind of understand what are the range of recommendations put forth. So what others have done, what exactly can we learn from the literature? And so to do this, we enlisted the help of a health sciences librarian who conducted a systematic search of 4 key databases: Medline, Embase, MCare, and Web of Science, using various keywords and subject headings relevant to the topic. And so this search yielded a total of 30,518 papers to review. As you can see from the Prisma flow diagram here, after various stages of screening, 173 articles were included in the final analysis. So the next few slides will describe the preliminary findings from the studies. So, we'll go into where the articles are from, where the discussion is taking place, who has been targeted, the types of requests made, the impact to the clinician, how others have handled this, and then moving on to recommendations. So when we started thinking about this work, we wanted to know where this conversation was happening. Is it a conversation that's predominantly rooted in the US? Is it happening broadly across Canada? Is it a North American conversation? Are there others discussing it? Are our colleagues across the pond having similar conversations? Who is having this conversation and where is it localized? So what this map is showing us is that the bulk of the publications on this topic comes out of the US. So it's telling us that this is a burgeoning area of inquiry within the US, and that the top 3 contributors to this conversation are the US, the UK, and Canada. And we're, this as evidenced by the number of publications here. It's also interesting that these 3 countries have deep colonial ties, but also have interesting migration patterns and immigration policies. And so as these countries become more diverse, so does the workforce, especially in the caring fields, which is kind of telling us that we can expect that this issue will continue to plague us as things develop. So as mentioned, we wanted to know where this conversation was taking place geographically, but we also wanted to know where temporally this conversation is located. And so to this end, there were no limits on the search that we did. We wanted to see how far back we could go. And from this, we noted that the first publication on this topic that we could find went as far back as 1980. And so this graph is showing us many different things, one of which is a drastic increase over time in the number of publications. So we're seeing more and more people chiming into this conversation, so much so that we can note the difference between 2016 around here and then 2023, etc. over here. So we're seeing a drastic increase here. We can also see more continuous discussion over the last 10 years in comparison to a more sporadic introduction between the 1980s and the 2000s. But interestingly, so in looking at this, but then also kind of stopping to reflect on like the socio-political issues at the time of publication, and then the three countries that these publications are happening in, or the three kind of major countries. It had me kind of stop and reflect on the historical pieces here. And so if we think about the 1980s, or think about the first publication being around that time, this would be the 20-year mark of when Black physicians were allowed into the AMA, so the American Medical Association, into the US. And so, thinking about the AMA was founded in 1847, but then the ban against the inclusion of Black physicians didn't end until the 1960s. It's interesting if we start to think about, okay, what was happening during that period. So that being said, this is a time, so the 1960s is a time in which, the segregation of healthcare, like we're thinking about Black hospitals, we're thinking about who was allowed to be a doctor, we're thinking about who was allowed into these different professions. And so it's very interesting to think about this issue around requests for specific healthcare workers and refusals of specific healthcare workers when we're thinking about who was not allowed into, even just these professions on a whole. And so, same kind of history if we think about Canada's history around who is allowed into certain medical schools, the exclusion of Black people to certain medical schools, so McGill and Queen's. If we think about the history of nursing, if we think about, the fact that Black Canadian nurses had to go to the US for nursing school for a very long time because they were not allowed in Canada. So, thinking about these histories and what we're seeing in terms of when people, make these requests or refusals of care, it's really interesting. And that being said, thinking about this in terms of also, so Canada's history around segregated healthcare for Indigenous people, right? So like, what might that also look like? And so I would also be remiss if I didn't, mention also looking at this map and thinking about COVID-19. Of course, we have to situate the anti-Asian racism associated with COVID-19 and the very clear refusals of Asian care providers during the throes of COVID. So in sum, looking at this timeline temporally requires us to think about how this conversation has changed over the years, but also how it has remained the same. Okay, so beyond looking at the geographical location of the discussion, we also wanted to know from a disciplinary lens and from a physical location lens, so healthcare setting-wise, where the discussion is situated. And so what we're seeing on this slide is that the articles on the topic are dispersed primarily in the medical, nursing, interdisciplinary health, and ethics domains. So these were the top 4 disciplines in which journals are represented on the topic. There were also sporadic publications in journals across the fields of pediatrics, psychology, occupational therapy, law, physiotherapy, social work, and pharmacy. In terms of clinical context, one of the salient findings from the review was the fact that these issues were rampant within the provision of nursing care, emergency departments, internal medicine, and primary care settings. Lastly, we also wanted to know, is this an issue that's specific to hospital settings, or is it occurring in other care facilities? And so as the pie chart indicates, 84% of the studies we reviewed reported an instance within the hospital setting. So also a mixture of academic teaching hospitals. Other settings reported included residential care settings, community care settings, rural care facilities, medical centers, and public or private service centers. And then just broadly, in terms of the high-level topics covered in the literature, we saw discriminatory language or behavior from patients, refusals of care, healthcare worker experiences of bias or discrimination, and then healthcare worker experiences of sexual harassment and responding to discriminatory patients. So these were the main buckets. Okay, So naturally, we had questions around who was targeted. And so when we think about the interdisciplinary healthcare team, we wondered if there were particular groups that were targeted more than others, why, and what's the context around this. And so this yielded some really interesting results. The chart on the top right corner shows us that the majority of the articles focused on physician experiences. Interestingly, 50 of the 102 articles on physician experiences were focused exclusively on the experiences of medical learners, so in particular, residents, interns, and trainees. And of those articles that examined the experiences of learners, they predominantly described experiences of discrimination that were racially motivated. There were also many experiences that were not necessarily identity specific, but focused on one's status as a learner. So refusals of the refusals of care providers, but based on one's status as a learner, which is a nuanced area that definitely deserves more attention. And so similar trends were observed for the physician group insofar as experiences of discrimination were also majority racially motivated, followed by experiences of discrimination focused on gender identity, religious identity, and sexual orientation. Okay, so once again, the focal point of discrimination experienced by nurses here was racial background, whereby requests or refusals were rooted in the racial background of the nurse, followed by the gender identity of the nurse. So similarly, we also observed trends in terms of the requests and refusals based on sexual orientation and one's religion. In both the physician group and the nursing group, there were multiple examples of discrimination that were aimed at multiple axes of one's identity. So it's important to know that while we might be seeing an overwhelming focus on one's racial background, it's often the case that discriminatory statements were wielded at multiple aspects of one's identity. So it's important to kind of note that piece there. And so what we did find, so bringing it back to the title of our talk, that there was an overwhelming focus on Black nurses in the literature. And interestingly, this holds true for the stakeholder interviews that we did across UHN in terms of trying to understand what were the experiences of our healthcare workers. And this was a finding as well, insofar as the nurses spoke to the extremity or the violence of anti-Black racism. Okay, so in terms of the types of requests made, so various experiences were described in literature. We grouped them according to three major categories, so discriminatory remarks, discriminatory requests and refusals, as well as assaults, which included sexual assault, as well as violent behavior directed at the healthcare provider. And so experiences of discrimination were based on racial identity, gender identity, accent or language, age, ethnicity, sexual orientation, religion, class, disability, and country of training. And so what we're seeing on the screen are some examples where the primary forms of discrimination were evident. So anti-Black racism, anti-Semitism, homophobia, Islamophobia, but there might have been other forms of discrimination operating as well. So coming back to that piece around intersectionality, sometimes it's never just one axis that's targeted, it's multiple. However, also really wanted to kind of come back to this point where the literature is dominated by attention to what like a common phrase in the title of many studies, the racist patient. Okay, and so the literature outlines key psychosocial impacts of these experiences with notable negative implications for one's psychological well-being, one's self-esteem and confidence, job satisfaction and job performance. And we're seeing where there was a explicit mention of experiencing racial fatigue, of feeling powerless, of engaging in self-loathing, of awareness of one's visible identity markers, of wanting to mask one's identity markers as a result of the continual exposure to this. We've seen where people have said no longer feeling joy from the job, doubting whether they could continue to care for the patient, question the duty to care. So we're seeing where the psychological and the emotional, the impact of these experiences is not insignificant. Like this is serious. And so a variety of individual responses have been described in the literature. These include de-escalation, transferal of care, direct confrontation, accessing support from others, reliance on institutional guidance, and boundary setting. We've also found some problematic responses. So for example, we're seeing where folks have reciprocated the negative behaviors or normalized the patient behavior. So we wouldn't necessarily endorse these, but still wanted to highlight that many things have been reported. And so we're seeing, de-escalation techniques as helpful for some, whereas others might really benefit from a direct confrontation approach to addressing things. So there are a variety of things available in the literature. And then in terms of individual recommendations for navigating these experiences, the literature highlights key recommendations geared at each of these roles. So the targeted healthcare worker, colleagues, peers, bystanders, the supervisor or those in a managerial role, recommendations aimed at the team, at preceptors, and at learners. And so in the interest of time, I will really briefly touch on the first two, so targeted healthcare worker and then colleagues and peers. And so in the scoping review, we started collating the recommendations geared at each role. And so what you're seeing on the screen is a summarized list of like the high level recommendations provided for responding in the moment. And so, what we're seeing is, steps like assessing the reason for the biased language, behavior of the request, setting clear and explicit boundaries when these types of behaviors occur, addressing the comment in real time, so avoiding silence, minimizing, avoiding any form of minimizing of the experience, avoiding a back and forth kind of banter with the patient or the family, ensuring that one addresses the behavior to not just protect themselves, but also to protect other patients around them, assessing the clinical stability and decisional capacity of the patient, clarifying roles and challenging stereotypes, so kind of aligned with that tactic of direct confrontation, and then documenting the interaction with the patient. So we're seeing where there are clear recommendations here, which might be helpful for those who are, when these happen, when these instances happen, people react in different ways. Some might become immobilized because of the shock of it all, whereas others might, quickly snap into action. So, different folks react in different ways. And so this might be helpful for those that are currently looking for ways to respond. And so for colleagues, peers, bystanders, what came out as salient was the need to, be an ally. So the need to, the importance of solidarity was really important here. And so we're seeing this piece around demonstrating allyship and supporting the targeted colleague, this piece around advocacy and speaking up for one's peers, and, really making an effort to show the, I guess, targeted healthcare worker that you're there and that they're not going through this alone, that there's somebody there to support them. Okay, and so in terms of institutional recommendations, these were grouped so there were many institutional recommendations. They were geared towards policy, education, research, and then the need for crosstalk between institutions and professional bodies. And so this slide essentially focuses on the policy recommendations, which were really oriented around the importance for action-oriented structures or procedures within the policy, and ensuring that any policy is really centered on the healthcare workers' experiences, and ensuring that learners are prioritized. So what we're seeing coming up as salient in this literature is the fact that where this issue occurs to learners, there's a massive gap. And so under the policy bucket is this need to attend to resources and support. So we're seeing, the need for providing communication tools, ensuring signs and posters are placed within the institutional walls, but also within the policy. We're seeing the need for mentorship for learners to ensure that they feel comfortable doing this. We're also seeing the bucket around institutional culture. So really and truly stressing the importance of accountability and also ensuring that the culture is one that attends to racism and it's safe to do so. And then lastly, the piece around monitoring and reporting. So creating standardized methods of reporting and tracking and ensuring that longitudinally there is attention to this in a way that is systematic. And then to wrap up, okay, so the policy pieces in terms of, institutional recommendations, as I mentioned already, policy piece, the education piece really looked at implementing training on this topic. It spoke to the need to ensure that health professions education on a whole builds this into the curriculum, ensuring that there is learner-specific engagement and education on the matter, and that across the board, EDI training acknowledges or really embeds this piece as well. In terms of research, there was this foundational piece on ensuring that anything that is put into policy is evidence informed. So ensuring that there's a research behind it that ensures that anything that is implemented is really backed by science or backed by the research. And then also ensuring the evaluation of any form of anything that's implemented. So ensuring that over the long run, this is still working for those who are impacted by it. And then lastly, professional bodies. And so I won't go very deeply here as this is Akosua's point, but the major point here was around the need for crosstalk between institutions and professional bodies, but also to ensure that these professional bodies are acknowledging this as an issue, like this is a core piece of it. And on that note, I will stop sharing my screen.
Thanks so much, Claudia. So just kind of keep picking up on that point. From the scoping review, we saw quite a few recommendations made for professional bodies in terms of establishing policies and guidance on how to respond to biased or discriminatory behavior from patients. This is because many would turn to and rely on their regulatory body to provide guidance on navigating those challenging clinical encounters. So what we really wanted to do was explore our own local context and see if and how our professional colleges acknowledged and addressed this issue. So within Ontario, the various health professions are regulated under the Regulated Health Professions Act, as well as other profession-specific acts like the Medicine Act or the Physiotherapy Act, for example. And so these colleges are responsible for regulating their respective professions, and they're mandated to protect the public by ensuring competent and ethical practice. This notion of protection is often quite one-sided, as there are frequent issues for which regulated health professionals need protection for that continue to remain unaddressed from the colleges. And there's another interesting challenge that arises within that tension between the protection of the public and then protection from the public for these regulated health professionals. So in this section, I'll really explore how some of Ontario's colleges have both conceptualized and addressed issues of equity, diversity, inclusion versus anti-racism, as well as whether or not they've begun to think about discrimination directed towards their registrants. And so Ontario has 26 regulated health professions, but our analysis focuses specifically on the resources from the colleges you see here. So the College of Audiologists and Speech Language Pathologists, dietitians, nurses, occupational therapists, pharmacists, physicians and surgeons, physiotherapists, psychologists, registered psychotherapists, respiratory therapists, and then social workers and social service workers. Given the larger project and that it was focused on revising the guideline for an academic health sciences hospital at UHN, we deliberately chose these colleges as they're represented, but within the professions that are typically present in the institution's interdisciplinary team. And so in kind of teasing apart this larger issue of navigating discriminatory requests and refusals of care, we necessarily have to involve and attend to the kind of intersection of various areas. So the intersection of EDI, anti-racism, professional conduct, therapeutic relationships, and then boundary setting as well. And so for the purposes of our analysis, in order to assess the college's stances on, as well as their general guidance towards navigating individual instances of this, we had to critically examine the overall attention to bias and discrimination and whether or not they had conceptualized this as issues affecting healthcare providers. So as such, we looked to see if the colleges had public commitments or statements around equity, diversity, and inclusion, as well as anti-racism. Then we looked to see if and how discrimination from patients was captured and whether or not it was noted as an issue affecting registrants. Before I move forward, I do just want to give a bit of a disclaimer that the analysis was really based on the publicly available documents of the respective college websites. So we acknowledge that as non-members of these different colleges, we might have limited or restricted access to kind of the fulsome content that may be available to the members. So just wanted to flag that, as well as the fact that any newly published material made accessible within the last month and a half is also not captured here. And then, as I noted prior, we only included 11 of the 26 colleges. So just wanting to note that the colleges that weren't analyzed might have their own stances or resources on the matter. But again, for the purposes of our project, focusing on these core 11 as they relate to the interdisciplinary team within our healthcare system. So just saying this to kind of acknowledge the specific context and the limits of the claims I'll be making. And so our analysis on EDI included examining whether the colleges had an EDI commitment and what those commitments entailed. So for the purposes of our analysis, we examined the documents that came up after searching equity, diversity, and inclusion, and then EDI, and the explicit statements or commitments that were identified through this process. So we're really ultimately looking for whether or not the colleges made some sort of attestation towards addressing notions of inequity, addressing lack of diversity, or the need for inclusion in the work that they do. And so of the examined colleges, 6 of them shared a public commitment to EDI, and these 6 include the College of Audiologists and Speech Language Pathologists, occupational therapists, physicians and surgeons, respiratory therapists, and social workers. And 2 key points kind of came out of this analysis. The first being the unidirectional nature of the commitment. So very much a specific focus on provider to patient interactions. And then the second being kind of the context in which EDI was situated. So with respect to the first point, all of the commitments reference their mandates and really emphasize the importance of public protection. And so the colleges use language like committed, acknowledge, honor, respect, and embody to really highlight this point. These commitments were all externally facing, and they all really attended to how EDI could be integrated into applied practice, most without specific action-oriented steps that explain how the college themselves intends to integrate it. And overall, there was a bit of a lack of attention towards the experiences of health professionals and how they themselves might be subject to inequity, exclusion, and might benefit from diversity initiatives. The commitments were found in 3 key places. So they were kind of contextualized either within a resource page, a standalone statement, or really integrated into a strategic plan. And so the resources page for the CPSO, so the College of Physicians and Surgeons, and then the College of Physiotherapists, both linked to articles, resources, and guiding documents on how to inform oneself about different EDI subthemes, and then how to practice with EDI at the center. And so those 2 commitments really, with their associated resource pages, spoke to that kind of action orientation piece where they provided guidance on how to integrate EDI considerations or concepts into your daily practice. But again, it's still that kind of unidirectional provider to patient application. Only the College of Occupational Therapists released a standalone statement on EDI, and that was just a kind of independent published statement that wasn't associated with resources or a larger plan. And then the colleges of audiologists and SLPs, respiratory therapists, and social workers considered EDI as strategic priorities within their strat plans. In addition to examining the EDI statements, we also evaluated whether or not the colleges teased anti-racism apart and how that relates to their obligations to the public, their obligations to their members, and then what protection means in those instances. So for this analysis, we really identified the anti-racism statements based on the language the college used. So a reference to systemic racism, to anti-racism was shared amongst the colleges and was a core component of an anti-racism commitment. Like the EDI findings, 6 of the 11 colleges had distinct anti-racism statements. And here on the slide, you can see an example of the College of Psychologists on the left, and then the College of Audiologists and SLPs on the right. And these commitments were to anti-racist action that leads to changes in how they carry out the public protection mandate and the collegiate operations, so really college-focused, and then also to addressing systemic racism and bias relating to services provided by their registrants. So again, a strong focus on the public protection piece, both in thinking about how the college functions, but also in terms of service provision by the registrants. These commitments were also quite unidirectional and didn't speak to protections that might be available or protections for their registrants. In terms of specificity, the College of Psychologists and the College of Occupational Therapists both specified anti-Black and anti-Indigenous racism within their commitments, and the others committed more generally to general anti-racism. And then also the College of Registered Psychotherapists added a commitment to communicating about their anti-racist actions with members and stakeholders as well, which really kind of hit home that point and emphasized that accountability piece as an important component of their commitment. And so the anti-racism statements were predominantly released in June and July of 2020, with the College of Dietitians following with the last anti-racism commitment in December of 2020. On May 25th, 2020, George Floyd was killed in police custody, which then sparked protests across the US and Canada. And there was a lot of social attention paid to institutions and their positions on police brutality and systemic racism. And we raised this analysis and show this on the timeline to indicate that prior to the murder of George Floyd and the kind of associated Black Lives Matter protests, there weren't any public commitments to issues of anti-racism. And that therefore begs that question of how were these issues dealt with, how were they raised or even attended to prior? I don't mean to imply that just because there was no public commitment that the colleges were silent on this issue. We just really want to highlight the social pressures and the global outrage that it took for a public commitment to be actioned. And then that still being said, just because there is a public commitment doesn't necessarily mean that the internal policies, guidelines, or ways of conduct within the college have meaningfully changed. This is where that specificity and accountability of anti-racist actions is really important in order to see if these commitments had a real impact on the people that they were made for. Okay, and so as I mentioned earlier, we were really interested in teasing apart if and how the colleges saw EDI and anti-racism as separate, and whether or not there was a conflation between the two. And so it's often the case that one is kind of considered or subsumed under the other. And so we were curious to see how the colleges were thinking about these two concepts in relation to one another and what that meant in terms of their public commitments. So most of the colleges had either a commitment to EDI or to anti-racism. Only the colleges of audiologists and speech language pathologists, and then occupational therapists as well, had separate commitments to both. In terms of how they were represented, we saw differences there. So we saw that the EDI commitments were kind of split between resource pages, strategic plans, or standalone statements. But for the anti-racism commitments, we saw them all released as these distinct standalone statements. In terms of timeline as well, where all the anti-racism statements came out in 2020, we also looked to see when these EDI commitments were made. And they tended to be much later commitments. So the standalone statement from the College of Occupational Therapists being released in 2022, the strategic plans for the College of Audiologists and SLPs spanning 2021 to 2025, the strategic plan for respiratory therapists being 2022 to 2024, and then the resource pages having unknown published dates. The earliest EDI commitment was in the form of the College of Social Workers and Social Service Workers strategic plan, and that was 2020 to 2023. So again, this kind of just speaks to the socio-political context and really the pressures that led to the release of these anti-racist statements. It was also interesting to see, with respect to my earlier comment around the kind of conflation of EDI with anti-racism, was how the colleges actually operationalized the terms and to see how a lot more tended to fall under EDI than anti-racism. So to speak specifically to the colleges of physician and surgeons, and then the College of Physiotherapists as well, they both used EDI as a larger category under which they had resources about things like cultural humility, allyship, anti-Black racism, and anti-Indigenous racism. So from a resource standpoint, we saw that anti-racism was often considered a sub-theme of EDI, but from a commitment standpoint, they were kept quite separate. And then the last thing I want to mention on this slide is that you might have noticed that the College of Nurses didn't have a publicly available commitment to either EDI or anti-racism. They do have an inclusive and culturally safe care resource page, and they provide resources on anti-racism there. And kind of most notably, they reference the Black Nurses Task Force report, which is a task force created by the Registered Nurses Association of Ontario, so RNAO. And that task force surveyed Black nurses on their experiences with racism in the profession. And the report really spoke to some of RNAO's efforts to address systemic racism in the nursing profession in Ontario and kind of globally as well. As part of their report, the task force did list the development and enforcement of zero tolerance policies of racism and discrimination from patients, family, staff, and nursing leaders. So despite the fact that the college didn't have a publicly available EDI or anti-racism commitment themselves, in the same way that the others might have, they do point their registrants towards materials that they're able to access. Okay, so ultimately, we really wanted to see if and how patient bias was recognized as an issue affecting college registrants, and then what resources were available to them. I will note that when I say patient bias, I'm speaking to all forms of discriminatory comments or behaviors from patients. I don't intend to underplay the severity or the seriousness of some of the quite bigoted acts that healthcare workers have been and can be exposed to. So just wanted to say that there. But this issue was really often spoke about using language like discrimination from patients, discrimination towards providers, and this idea of how healthcare workers have human rights too. And so 7 of the colleges mentioned or spoke about patient bias in some way, whether that be through policy, practice notes or practice guidance, or links to academic journal articles. And these 7 are the colleges of audiologists and SLPs, OTs, physician surgeons, social workers, physiotherapists, psychotherapists, and pharmacists. But another interesting way in which some of these colleges broached the topic was through the context of terminating the patient-clinician relationship. So 6 specifically spoke about patient bias in the context of ending the therapeutic relationship, while 3 spoke about it generally outside of that context. And those numbers don't add up evenly to 7 because they're split. So the College of Audiologists and SLPs only spoke about patient bias generally and not within the context of ending the therapeutic relationship. And then the colleges of OTs and physicians and surgeons addressed it both within and outside the context of termination. And so, again, the 3 colleges that spoke about it more generally, coming from as bias or discrimination coming from a patient or client, were the colleges of audiologists and speech language pathologists, occupational therapists, and then physicians and surgeons. And on this slide, I'll populate it and really highlight some of the resources that are available, and then discuss what's helpful and what's potentially lacking from the various college guidance. And so the first image here that I'll show is an example of practice guidance from the College of Audiologists and SLPs. And here they provide suggestions for registrants on how to manage a situation where a patient makes discriminatory remarks. An interesting element of the discussion on patient bias is this idea of responsibility. So is the patient making discriminatory comments due to a head injury, as we can see in this example, or maybe something impacting their capacity, or, do they have capacity and they're just making or holding problematic beliefs? And so the guidance from this college is really helpful in that first case where discriminatory behavior or remarks might be attributable to the patient's condition, but it still leaves registrants without guidance in instances that aren't similar to that. So in the opposite case, where the patient may be fully cognizant of their behavior and potentially making the active choice to be discriminatory. In response, the college does recommend implementing patient-centered strategies that both address and modify the patient's inappropriate behavior. They recommend collaborating with colleagues who might have expertise in the patient's clinical condition to see if there are additional methods that could be used. But this guidance is a bit high level and kind of really leaves it to the individual to rely on their clinical judgment to figure out what is the most appropriate way to navigate the situation. And so relying on registrant skills without necessarily educating them on how to navigate these situations or providing them with a pathway or guidance really assumes that people have these skills. And these can be quite challenging and confronting situations. So this reliance on clinical judgment and skills can still mean that individual clinicians are unsure of how to move forward. And even as Claudia mentioned earlier, it can be quite immobilizing. So even still, you might have the skills, but still might not be able to respond in the moment. Another interesting resource here were these kinds of recognition practice statements or practice notes that really emphasize that idea that healthcare workers have rights too. So here you can see the College of Occupational Therapists, OTs have human rights too document, which really emphasize that registrants have a human right to work in environments and with clients that are not racist or discriminatory. Additionally, you can see that the CPSO recognize that physicians share this right to be free from violence, harassment, and discrimination in the workplace. and acknowledge the emotional, psychological harms that can come from discriminatory patients and incidents of discrimination. So something we'll kind of talk about a little bit later in the context of termination is this idea of a rights framework versus a safety framework. So some professional bodies will really base it in that legal human rights framework piece versus a safety framework, which thinks more about the safety of the provider, the safety of other staff, and the safety of everyone involved in the situation. The College of Physicians and Surgeons has quite a few resources for responding to discriminatory or biased behavior from patients, including, as I mentioned before, links to various articles. They have internal publications on the topic, and they do have college policies that apply as well. And so this last clipping comes from their advice to the profession document that speaks to their human rights and the provision of health services policy. And so while this is just a short snippet of that whole document, in this particular spot, they talk about, well, they provide guidance on what to do and what to consider when deciding if a patient's request for a specific care provider based on any identity characteristic is reasonable. And then from here, they kind of provide two pathways, whether the request is reasonable or not reasonable. For reasonable requests, they do provide the example of requesting a provider based on religious or trauma reasons. And there they recommend that physicians take appropriate steps to accommodate the request where resources are available. So acknowledging that kind of resource limitation potentially. On the other hand, they provide the example of requests based on racist beliefs. And there they recommend that physicians determine safe and appropriate steps to take. So encouraging registrants to sensitively explore the reasons for the request, recommending that they consider the patient's mental and physical state, the urgency of their medical needs, as well as the safety of everyone involved in next steps. And those next steps could then include kind of either continuing to provide care or transferring to another provider as well. And so these four examples really speak to the diversity of resources that are available, whether it be more applied like the CPSO or the CASLP examples that tell you kind of what to do when faced with X behavior, when faced with X request, or they can be a bit higher level in kind of establishing these expectations around what a health professional should be protected from. Something else that we saw emerging with respect to kind of these explicit mentions of patient bias were these employer recommendations for supporting registrants in instances of patient bias or discrimination. So one example would be the College of Nurses. So while they didn't necessarily have language around discriminatory patients, they did discuss what's necessary to maintain a quality practice standard. So there they set out strategies for employers and nurses to kind of develop and maintain a quality practice setting. So doing things like supporting staff requesting a change of assignment due to stress or boundary issues, having resources to assist nurses in situations where establishing a therapeutic relationship is particularly challenging, having zero tolerance for abuse, having known procedures for reporting that abuse, and then ensuring that those reports are investigated and addressed. So it's just kind of interesting to think about some of the levels that the colleges make recommendations at. So whether it be the individual level for those who might be directly faced with a biased or discriminatory patient, or whether it's more at an institutional level and thinking about what policies, procedures, or structures can we have in place to support those individuals. And so coming back to this notion of termination, I do want to note that every college had provided information on therapeutic relationships that included kind of appropriate boundaries, when it might be appropriate to discontinue services or terminate the relationship. And 6 of the 11 colleges that we analyzed spoke specifically to termination based on bias, discrimination, or abuse originating from the patient or the client. And so each of the colleges provided slightly different conditions where termination would be appropriate, some centering it more around this idea of therapeutic relationships, whereas others focus really on safety and considerations of harm. And just in the interest of time, I will say, although each college might have their own specific conditions, there are a lot of situations that are shared across the colleges. And there are quite a few shared themes there. So something interesting of note as well is that a lot of the colleges don't specify the kind of harm. So as you can see on the slide, you can see the risk for serious harm from the College of Social Workers, psychotherapists, physicians, surgeons, and OTs. And that really leaves it open for psychological harms in addition to physical harms. And so the harms for a health professional from verbal racial abuse can be incredibly severe. And the colleges allowing them and providing them a means to remove themselves from those situations is really important as well. So within the ending the therapeutic relationship, it is important to say that the colleges still expect registrants to uphold standards of practice in terminating the care relationship. They have to think about replacement services, they have to think about reasonable timelines, documentation, and overall minimizing the impact on the patient. So despite these potential risks to their safety and their well-being based on bias, discriminatory, or abusive language or behavior, healthcare professionals are still expected to uphold standards of practice in terminating those relationships. And by doing this, the colleges that provide guidance on terminating in these contexts are still able to kind of uphold their obligations towards patients, uphold and maintain their public protection mandate, while still protecting registrants and allowing them the opportunity and the freedom to choose whether or not to continue providing care to a patient that is actively being harmful towards them. And so in terms of take-home messages, if we reflect on the timeline that we saw first in the scoping review for how long this has been occurring, from our first identified article on this in 1980 to 2024 now, this really highlights it's been an issue that's been occurring for the last how many years. And I think that now we're much further ahead in terms of tools, resources, and thinking on the issue, that it's really important to now turn towards action. So there needs to be this collaboration and crosstalk between individual healthcare institutions and then the professional colleges as well, to really ensure that healthcare workers are adequately supported from various sides and various scopes. All of the professional colleges also need to acknowledge the impact of discrimination on their registrants, and then provide guidance on how to practically navigate these encounters. As Claudia mentioned, the policies at both the institutional and professional college level need to be evidence-informed and really rooted in the experiences and identified needs of healthcare workers. And then lastly, this piece around learners. So attention needs to be paid to the vulnerabilities of learners, and the learners ought to be explicitly considered within protection structures and resources.
And so on that note, we've started to build the foundational pieces for any kind of clinical education program or group wanting to reflect on the ethical considerations necessary in attending to these issues, especially as it relates to institutional policy on patient bias, but really kind of geared towards, from the lens of the learner. And so kind of, wanting to end on this piece on really kind of stressing, the added vulnerabilities in this area as it relates to learners, and the fact that, while other healthcare workers might have certain institutional protections or might have, resources or supports, as for example, EAP or that sort of thing that is available to healthcare workers, learners are not, the structure is very different. And so when we're thinking about this issue from the lens of the learner, it really is kind of channeling a whole different dimension and realm, and so the attentions there need to be that much more, matching. So really and truly kind of honing in on the need to attend to the nuances as it relates to learners. And so really wanting to just kind of conclude on that note. And so thank you very much for listening to us and for coming out today. And we encourage you to send us questions or further, email us if you would like to keep the conversation going. And on that note, I will hand back over to Ruby.
Thank you so much, Claudia and Akosua. I think we are at time, so I don't know, I don't think we have time for questions as we wanted to do that, but everyone can see the email address of both Claudia and Akosua, and please feel free to reach out to both of them for questions, for continued discussion. I think as a community, we will continue to be discussing these questions that we have for ourselves on this topic, but such extremely thoughtful and insightful research. And I know that this is part of a big, huge initiative that you're already doing at our institutions in general. So thank you so very much for providing this very critical, very, very deep information on this very important topic for us. And unfortunately, it's time to end our seminar today. And just a couple of announcements before we thank Claudia and Akosua. Our 2023-2024 JCB seminar series will be concluding as of today. For future seminar information, stay updated with our JCB event digest. If you want to sign up to receive our weekly seminar reminders and event digest emails, just email us at jcb.info@utoronto.ca, and this and you will be able to receive those updates as they come. And once again, Claudia and Akosua, this was a whirlwind of information to take in, but so thorough and so extremely well done. On behalf of all of us, again, thank you so very much for your presentation. Thank you.
Thank you so much.
Thanks so much, Ruby.